Sitting next to Dr. March, we have Dr. Dan Simon. He's the chief of our Division of Cardiovascular Medicine here at University Hospital's Case Medical Center, the Harrington McLaughlin Heart and Vascular Institute. And his degree was earned from Harvard Medical School and has come to University Hospitals. Previously was at Brigham and Women's Hospital, where he was associate director there. He's the recipient of numerous research awards. And we also have with us today Dr. Jessica Berg with us, who's a faculty member here at the university, professor of law and biomedical ethics, and associate director of the Law and Medicine Center. She had joined the faculty here in '99. Dr. Jessica has published in multiple journals, very well represented in the area of bioethics. And then also we have with us today Dr. Robert Findling. He's the Rocco Model Chair of Child and Adolescent Psychiatry at Case Western Reserve University, and also Director of the Division of Child and Adolescent Psychiatry here at University Hospital's Case Medical Center. So a very qualified panel here today, so apologize to keep those introductions short, but I think everyone's interested in moving on to some further discussion on the topic today on placebo. So we're just going to go ahead and allow for a little bit of comment from each of the panel members here, first of all.
So I guess I'm going to be starting because I'm immediately to your right. So let me just simply mention, first of all, thanking again John for coming here. As John and I have known each other for, a long time now, and have actually collaborated on the TAD study to which he's alluded. I think his mere presence here highlights the fact that this is something that always requires thought. I don't think placebo should ever be taken lightly. It requires thought. It needs to be considered carefully. And, you know, I think some of the data we have now we didn't have 10 years ago. And so our perspectives and understandings will consistently change as more data become available. And so at the end of the day, many of the things that John had mentioned are things we actually implement right here as far as our uses of treatments, including placebo, the adjunctive strategies, the discontinuation strategies, all of which are part of what we really do, because at the end of the day, it's still experimentation, regardless of whether there's an active compound or an inert substance. And certainly, whatever we talk about today will be old news in 5 years, if not less. So it's always something to think about.
I guess I'll limit my focus to one primary comment. I think there's a lot of the things in the presentation that we can talk about, and I know there were a bunch of questions that came in. But I think the most interesting issue from an ethics standpoint is to start to think about what does it mean to say you need to have an available alternative, especially given the fact that many of the things that we use that we call standard treatment have not been tried in any kind of clinical trial at all, let alone against a placebo. So talking about comparing something to a active arm, you may well be comparing it to something that itself only has a placebo effect, and I think that's important to keep in mind. The other problem with this idea of availability is that, does that mean available in the sense that it's available anywhere in the world? Does that mean available in the sense, or an alternative treatment? Would you accept non-allopathic medical treatments in that notion of availability if there's a complementary alternative medical treatment? So I think that's really where a lot of this focus gets down to. So if you say that you can use a placebo when you do not have an available treatment, well, what are you talking about then with that available treatment? What does it mean to have a sufficiently acceptable alternative? Acceptable to whom? The individual patient subjects who are saying, we don't like the effects of this particular treatment, or it's not sufficient yet to do what we want with it. So I think there's quite a bit in there that you need to unpack when you talk about when it's acceptable to use a placebo.
Chronic stable angina is a very, that's chest pain from blocked arteries, is a very common subject of clinical trials, and similar to depression, has anywhere from a 30 to 80% placebo effect rate when you do clinical trials. Yeah, it's a chronic disease that itself is not really life-threatening, so obviously is amenable, I think, to placebo-controlled trials. And in our field, which is highly technological, the active therapies now carry with them significant morbidity and mortality. And what I mean by that is trials of either stem cells, gene therapy, or even transmyocardial laser procedures. And what's interesting about all three of those treatments, which are very involved, is that they have not stacked up well in placebo-controlled trials. So very exciting phase 1, first-in-man data, very exciting phase 2 data, often in escalation of number of cells or number of sites and number of copies of gene that are injected into the heart, but when they actually go up against placebo, they don't fare well. So it's, I think, very important in our field that we look at adverse effects of active treatments, and also one thing we haven't touched on is that of expense and costs. And I'm reminded, I think, today of probably one of the most dramatic questions, and that is that of placebo surgery. And many of you know that arthritis is a big problem in the United States. We spend about $3.7 billion a year on arthroplasty procedures for arthritis of the knee. And there was a very interesting study published in the New England Journal within the last year that compared sham surgery to real surgery for arthroplasty. And there was absolutely no difference between active surgery and placebo surgery for the treatment of arthritis. And that not only has enormous implications for subjecting patients to operations, which are unnecessary, but also has the potential of saving the country $3.7 billion. So one could argue that although we haven't talked about the ethics of placebo surgery, which is a whole nother area, even in some instances, that's necessary to really ferret out whether patients derive benefits.
So I'll just make 2 quick comments because you've heard too much from me already, but given the latter example, we have to think about the consumers of this information, and the expectation is that osteoarthritis trial will not impact practice unless the payers or the folks who run health systems use that information to affect decisions about patient care, which is probably not going to happen because the monetary decisions move completely in the opposite direction. So when one thinks about healthcare decision-making from a financial point of view, all the things that we do to improve things, including showing that treatments don't work against placebo, run counter to all the things that we're doing in building, knee hospitals and heart centers and neuroscience hospitals and all this sort of get very interesting, that discussion. The thing that I would ask you to think about, to be sort of visionary and provocative about it, is to think about that slide I showed from Helen Mayberg, that co-localized prefrontal cortical cingulate and right parietal structures as active in the response, whether it's to placebo or active drug. Those are the same structures that show up in mindfulness, which is the ability to take the sort of mental intention and have it sit still without a lot of thinking. And that ability to pay attention and then to move via mental intention based on what you see is at the heart of what makes us human. So there's something about this placebo response which actually goes directly into the nature of what it is to be a human being, and to the extent that we can understand it, will actually help us clarify some things about who we are as individuals and in social groupings.
Excellent. Well, I see that there was a bit of a theme in some of the questions that people wanted to present to the panel this morning. So I'd like to start off by addressing an area that was brought up by one of the people in our audience today. So what are your thoughts on using the term nonspecific effects rather than placebo? In other words, trying to move away from a negative connotation, as well as promoting scientific inquiry into this particular phenomena. So any of our panel members want to comment on that?
Well, John's looking at me, so I guess I ought to at least start off and see what I can say. You know, nonspecific effects, I think, just as an umbrella phrase for many of the things that John had mentioned that he described in more specifics. You know, so there's there are a lot of research coordinators and from child psychiatry here today, and you know, they're really nice people, and they really understand that we are in our field to get kids better and learn how to do better by these kids. They're all young and enthusiastic, and they don't quite remember the days that I do within, gosh, John, the last decade when we literally knew nothing. But they know that we're there to help these kids, and you know, kids figure that out. Parents figure that out. And I have to tell you, you know, I like working with them. I can't imagine the kids not liking working with them either. They do a wonderful job. And at the end of the day, the whole issue is, how could that not be helpful? Moreover, you know, we all live very busy lives. Sometimes we hear from youngsters and their family that the drive down to UH is the only time each week a child can spend 45 uninterrupted minutes coming and going alone with the parent, not doing homework, not schlepping around to doing something else, not with all the other kids around. That's certainly non-specific, because it's certainly not pharmacological in the truest sense of the word, but for a lot of these kids, it's wonderful. They feel special about it. They actually have time with their parents in a way that they oftentimes didn't. So at the end of the day, just because it's nonspecific doesn't mean it really isn't good, but nonspecific is just what it means. It probably is a gamish of a variety of things, and I think John nicely described a bunch of them in his talk. Would that be a fair thing to say?
Yeah, I probably wouldn't endorse the use of nonspecific because, for example, the masking blinding function is specific to the physical structure of the pill, which is very specific. And then if you think about the ways that we are beginning to dismantle the placebo response in this sort of reductionistic scientific model, all of these are very specific effects. So to my way of thinking, the term nonspecific trivializes what actually is a very interesting and complicated process that needs to be deconstructed. And at some point, as we understand it better, we will understand how to capitalize on it in a way which actually makes use of it as part of the things that we do routinely. And that then will become a specific part of our therapeutic armamentarium. So I probably wouldn't use that term, at least at this point in time.
The NIH is using expectation effect more than placebo. That's the desired term.
You know, just to respond to that, I probably wouldn't use that either because it's a whole lot more than expectancy. People get sort of lost in this idea that it's all about expectancy, but it's infinitely more complicated than that.
And also then, we've certainly heard a very, you know, positive side of placebo. And so given that, is there a way that we could be putting more effort towards understanding how do we make placebo itself more effective and possibly then reduce the need for medications in the future, or just simply understanding how to improve placebo effect? So if the panelists have any reactions to that?
I mean, I think for clinical practice, it's a wonderful idea, right? You can not have to put anybody at risk for active treatment. I mean, for clinical practice, it would be absolutely spectacular. However, most studies that are conducted are meant to actually test whether something works or not. And so at the end of the day, you're, again, back to what John was saying before, it's really talking about assay sensitivity about things. So under the and I guess it's the same real analogy. There's a difference between treating people and treating them under the auspices, or at least managing their well-being under the auspices of a clinical trial. So I think in clinical care, if we could certainly learn how to harness the placebo even if it doesn't necessarily mean swallowing an inert substance, that would be wonderful, because in fact, what else could you want? All the benefits without any of the risks. But under the auspices of a clinical trial, the theme of assay sensitivity really rules. And so we have two different objectives depending on where we're seeing the patient.
So I have to say that my first thought was, well, what would you compare it to in the trial of placebo? It's an interesting concept, right? So one of the difficulties from an ethics standpoint is the deception aspect of using placebos. And I think actually in clinical care that's even more problematic, because getting over the problem, which I think is an acknowledged very difficult problem of getting an adequate informed consent and bypassing a therapeutic misconception, at least in a research trial, you've notified the individuals they have the possibility of getting placebo. I have never seen a physician in a clinical encounter start the discussion with the patient with, I'm about to treat you. I might be giving you an inert substance, or I might be giving you a placebo. I'd like you to consent to me either giving you something active or not giving you something. I mean, I think that raises some very difficult issues in the relationship. So although I agree it'd be a nice world if we could essentially have positive effects without any of the negative ones, there's two problems with that. One is the deception. The other, quite frankly, is that since we see the side effects sometimes manifest with the placebo, I'm not sure if you'd, even in the placebo world, have no downsides.
And I guess I wasn't clear. Let me just be very sure I'm being clear. I was not talking about using placebo in clinical practice. What I was saying is learning what placebo effects are without the deception, because if we knew what we're getting people better with placebo under the auspices of clinical trial, you could implement those techniques without the deception to which you're alluding in clinical practice. So I just didn't want anybody to think I'm talking about deceiving patients under the auspices of clinical care. It was more about if we learned what was the active ingredient of placebos, whatever that was, we could use it in the delivery of care without the deception.
We do, in fact, have a little bit of research about the Hawthorne effect. We have a little bit of research about what happens for patients in their interactions with caregivers. We have a little bit of research on the environmental effects of how you set up your, as simple as how you set up your patient waiting room to how you set up your exam rooms. I mean, we do look at the rest of the things that make a difference to patients in getting better. Now, we don't understand entirely everything that goes on in a placebo effect, but we do know that one aspect of it is not knowing you're getting the placebo. So that deceptive part of it is the part that I get stuck on. So although I think we do want more research on what can we do to help patients overall without exposing them to additional risks, I'm cautious in whether or not, trying to figure out every aspect of a placebo effect is really going to get us where we want to go there.
Let me make a comment about the slide that I showed you on the meta-analysis from the Finnish group, the Cochrane analysis that compared placebo to no treatment. That analysis was done in the context of the clinical trial, so the no treatment condition, where they were not getting a pill or whatever the intervention was, included all the other bells and whistles of a clinical study, the assessment packages, the informed consent process, all of the things that would happen. I don't think anybody believes that if you simply toss people out of the healthcare system and make no treatment follow the two words directly, that is, you're on your own, buddy. You're not getting anything from anybody. Maybe you can go down to the drugstore is not going to serve patients well. So if we actually ask the question, how is placebo doing in a research context relative to not getting anything from anybody? What you have in that difference is all the good things that placebo does in a clinical trial context. And I think what we've been saying is we have to figure out how to take that and operationalize it so that we can use it as part of clinical care and understand it in a research context so that we can confront it when we need to maximize assay sensitivity and to capitalize on it when we need to, particularly in pragmatic trials.
Another question we had was whether there's any research on the pharmacogenetic placebo response.
So there is actually quite a bit of work in that area, and I thought about reviewing it to build this talk, and there just simply wasn't time to do it. So yeah, I think it's really important to, not just the genetics, but all the omics platforms. It might be that there's epigenetic mechanisms, or there's a proteomic or metabolomic signature. So I think that one of the things that the NIH wants to do more of is to database biospecimens covering the imaging and omics platforms, so that we can look for biomarker biosignatures of, among other things, the placebo response. And that's going to be a really exciting, interesting topic of discussion over the next 5 years.
And what about the measurement for placebo effect? Do we have any evidence of what that measurement, would it be a unit or a gram or a liter? And are we doing anything in the field currently to look at how we measure the dosage?
Well, the unit is whatever the clinical trial endpoint is. So it's no different than the active treatment in that sense. And the dose of it is all the things you do with the active treatment, except that it doesn't contain the active treatment. So in this orthopedic surgery trial, everything was held constant, except the arthroscopist didn't go in there and rearrange anything. Actually, I really apologize. I should have put that slide in because I knew about that trial. It's a really, really interesting study with enormous implications for the healthcare system.
And just thinking a little bit, tying the placebo and the notion of the explanation of placebo back to the interaction with the research participants and the families. So really, at the time of the consent, when we're doing informed consent, is really when we're evaluating kind of the baseline, if you will, for what is their understanding of placebo. And my own experience in working with families and people affected by Alzheimer's disease is that you also, though, needed over time to reinforce that concept. And of course, Alzheimer's is a progressive disease. There's no cure. The treatments we were looking at that time were basically to try and slow the progression, which can be sort of an odd thing at times. Some of the family members would say, well, why would I want to do that? Why would I want to prolong the suffering? But many of the families needed kind of reinforcement along the way about what placebo was, and wanted to know whether their family member was on placebo or not, particularly when they would start to see maybe some exacerbation of symptoms. And I know that this was just something that our team worked at very hard to just constantly re-educate and help reconsent in a way the families to help them understand that. But do you have any kind of wisdom or approaches in particular that you use during the consent process to help the participants understand placebo?
Yeah, I think this is a very important point, and I think of some of our stem cell trials where we actually isolate cells from the patient, but then certain patients only get back saline. I mean, they just get back salt water, and I think it's very important for them to understand that they will go through an injection procedure, but typically in these 3-arm phase 2 trials, they have a 1/3 chance of, even though we harvested their cells, that they may only get saline back. And I think you have to be very, upfront with them that there's a 2/3 chance that they'll get stem cells and a 1/3 chance that they won't. And that the benefit of this procedure for them is that they're going to help us figure out whether or not this therapy is useful. But I think that it's most of the patients that we get are at the end of the line, so they have no options. So they figure that a 2/3 chance of getting something is better than a 1/3 or no chance at all. But we also are, I think, pretty upfront with them that although there's reasons to think that therapies could work. We really don't know. So we really have to, there has to be a placebo group.
Yeah, I think the ongoing issue is really interesting, right? So we know that you can often get patients to understand the concept of a placebo. What the therapeutic misconception does is that they understand the concept abstractly, but if you ask them what they think is going to happen in the actual trial, they'll start to say things like, but of course my doctor would make sure I didn't get the inactive arm, right? I can't be really getting that. And in fact, one interesting issue is I think it's very, very difficult in the trials when you have kids, because you don't always, in addition to having the issue with the kids themselves and trying to understand it, parents, we haven't studied this in as much detail as I think that we need to. It's very difficult to navigate the therapeutic misconception with parents who find it quite difficult to grasp the idea that their kid might not be getting an active treatment arm. So that in itself makes it more difficult. What's really interesting, though, is that even people who do grasp the whole concept initially and even say, you know, I even understand that I might be getting the placebo arm, as the trial progresses, start to have very clear ideas of whether they're in the active arm or the inactive arm, not always related to whether or not they are in the active or in the inactive arm. And those beliefs themselves can be very, very difficult to move one direction or another. When we think about informed consent, we obviously focus very much on the initiation of the trial. We talk about the fact that you need a continuing understanding of what's going on as you continue in the trial, but we very rarely push hard to really maintain that. And I'm not sure what you do about that. I mean, knowing how difficult it is to deal with the therapeutic misconception at the outset of the trial, it is likewise extraordinarily difficult as the trial continues to get people to continue to understand, you know, we don't know which arm you're on when they're telling you, I absolutely know for sure that I'm not getting the active one, or I absolutely know for sure that I am, and I can tell you all these reasons why. So it's really interesting, and part of it is people's beliefs about, and things maybe that they have to believe, especially in end-of-life care things or in sort of last option areas, of what they have to think is happening as they continue to accept this. And I've never been entirely clear on how comfortable we ought to be with that, right? So from a very sort of outside perspective, you want to say, well, no, we really just want you to understand everything perfectly at all points. But from a much more personal, you know, this is an individual having to deal with things through their both the course of their treatment and the research that's happening. It's hard to say what you want to do each time the person comes in and goes, you still understand, right? We don't know what arm you're on. You still understand. We can't even talk to you. I mean, that's not exactly what you're thinking is going to be going on. So I think it's an uneasy tension, the sort of ongoing issue.
Or occasionally we would have an example of, you know, the family member wanting to know now what they're, you know, if they were getting active medicine or placebo, and then, of course, we weren't able to disclose that information. Sometimes families, you know, may not ever actually receive the results of their clinical trial participation, which I think is a bit of an ethical issue as well.
We certainly see cases where subjects have died and families are adamant that they want to know what arm the individual was on. Which raises some interesting questions when you haven't quite finished where you're at to let them know the information. So I think that's going to be there.
I mean, I think there's a lot of anxiety around placebo for families, and I think at the end of everything else, what, other than the cognitive experience that people are talking about, what we really do try to strive to convey is the child is more important than the study. And as long as you can establish, you know, relationships matter. That seems to be a theme about a lot of things. If parents are left with the understanding that you have their child's best interest in mind, and if things usually actually get better regardless of their treatment arm, as John has mentioned, but are you going to be there if something goes really wrong? Are you going to be available? And, you know, the fact that we have a 24-hour, 7-day-a-week, 365 research pager for a parent to call for all kinds of emergencies, as well as all kinds of guidance questions. That sensibility, I think, matters just as much, I think, at least for us, because these youngsters have suffered so much for so long, and they've struggled oftentimes to find answers. or at least people who are willing to listen to them, that the ability to understand that the child is more important than the study. And amongst our research group, that gets iterated, reiterated, child first, study second. And I think that's part of that's just as important as the cognitive constructs, is the commitment to the well-being of the youngster.
One of the things we don't do well in psychiatry, in large part because if you think about psychiatric illness relative to cardiology, we're treating patients with our interventions when they've had their first really massive heart attack, or often when they've had 3 or 4 heart attacks. I mean, we're basically treating end-stage disease at the point you make the diagnosis, because these illnesses are neurodevelopmental. They began many, many, many years earlier. Even in Alzheimer's, there's thinning in the entorhinal cortex in people who have the ApoE4 risk allele as teenagers. So if you think about the statin trials in cardiology, it sort of makes a nice example of where we'd like to be able to get to. We're actually doing the interventions to ward off the emergence of clinical illness. And in a trial like that, or in a trial where there's kind of stage things that happen, you have inflection points in which equipoise or uncertainty may change, or the person's cognitive capacity to evaluate their willingness to participate may change, as is true in moving from cognitive impairment into Alzheimer's disease. And maybe this exists, but in the context where I work at Duke, I don't think we have a set of sort of standardized procedures for a standardized understanding or a set of procedures for dealing with these inflection points that happen during trials, and we probably need to do a much better job of thinking through that question.
I think the other thing that clinical researchers need to understand is that new treatments are not as efficacious as we think, and they're not as safe as we think. And I think that it's really important, I think, when you're approaching your patients for new treatments in disease, that you really, I think, have it in your sense that you should be skeptical of the benefit and mindful of the risk, especially in interventional therapies. Our field, again, is all the new bells and whistles and toys and procedures that sound cool, but the bar should be set pretty high to think that they work. I think on the other side of it, I think it's also important to emphasize to patients that there is a DSMB, which is monitoring the trial, and that signals of overwhelming efficacy or signals of safety will trigger stoppage rules in the trial. So I think it's important for them to know that there is a protecting mechanism. Now, of course, we could argue that the DSMBs have to be basically hit over the head 3 times before they would ever stop a trial. And I've been on some DSMBs where we've been in tough situations because there's so much pressure to keep the trial going. But I think that it is important, and that is an important protection for research subjects, is that the trial can be stopped. And in fact, many of you know that just in the last 2 weeks, one of the trials comparing niacin to the addition of Zetia or ezetimibe to statins for carotid disease was stopped early by the DSMB. Now, a lot of us think it was curious and odd that they stopped a surrogate endpoint trial early for efficacy. It wasn't a clinical event trial, but I think that DSMBs do operate when they see that a therapy's not as good as another, both for efficacy and safety.
Another interesting thing that comes up in this context is if in pragmatic clinical trials we shift the context in which those trials are done away from academic health centers and into community practices, and this is actually happening in cardiology already, and happens all the time in cancer. We're now going to have the researcher doing research part-time most of what they're going to do is clinical care, and they'll enroll some of their patients, maybe 5% of their patients, in a clinical study because they like to be part of research. They like to make a contribution. It's a good marketing thing to say that you're affiliated with an academic health center doing research, and their patients like it. And yet, all of this stuff, which in the FDA world is called good clinical practice standards, is actually much harder to do in a clinical context than it is in an academic health center context, and it's damnably hard to do in an academic health center. So how we handle this, this issue of keeping a boundary between clinical care and clinical research for pragmatic trials done by real doctors with real patients in the practices in which those patients are found becomes an interesting kind of problem to solve with real ethical implications. It's clearly the way to go. I mean, it's going to give us much better data, much larger trials, much bigger sample sizes, so we can go looking for biomarker biosignatures. I mean, there's it's going to be more costly. There's every reason to do it, but this whole issue of the therapeutic misconception gets more intricate and difficult as we move into that kind of a platform for doing clinical trials.
Excellent. Well, I think we're getting close to our time for the program today. We perhaps could take maybe open one last question in the audience if there was anything that we haven't covered with the panelists. We've done an excellent job, and I think touching on the most kind of provocative areas, and certainly I think these conversations can go on for a long time. But are there any other questions that the audience wanted to ask? Could you please come to the microphone?
What kind of objective measures do we have of placebo effect?
Well, I think, as was indicated in terms of it's the unit of the trial that you're in, certainly in our chronic stable angina trials, whether it's anginal diaries or walk time on a treadmill, you can see that walk distance goes up and anginal frequency goes down with placebo treatments. And the question is, does the active treatment have an increased treadmill time or anginal diary improvement? One of our most recent stem cell trials showed, in fact, that walking distance did improve from baseline, and anginal frequency did go down with placebo, but the injection of stem cells led to further increases in both walking distance and decreased in anginal episodes. So I think that in this particular case of chronic angina, it was angina was lower, the number of episodes, and the treadmill time went up. So it was an objective, and it was an endpoint, a clinically meaningful endpoint is assessed by the FDA. Interestingly, the FDA was not as interested in the size of the ischemia defect by nuclear imaging as a endpoint, which some of us might argue is more objective because it gives you a volume of ischemic tissue, but that's sort of meaningless to the FDA with respect to, does the patient feel better and walk further because they have less, angina.
Did it change with placebo?
It did. It went up. Anginal frequency and walking time on the treadmill does improve.
No, but the actual...
The ischemic sign? No.
No.
The zone, no.
Yeah. But in the neuro and the psych studies, we're usually looking at perceived things. We don't actually have... I mean, does it change cognition scores?
I would love in psychiatry, and this is heresy to people who love empathy, and this is not meant to discard or in any way kind of reduce the value of an empathic doctor-patient relationship, but wouldn't it be wonderful in psychiatry if we didn't have to ask a single question? We had reliable biomarker or biosignature panels that could make diagnoses and track outcomes without being so reliant on interviews. Go back to your original question about what, how do you measure this? If you look at the calculation for effect size, it's the mean of the active treatment minus the mean of the control treatment divided by the pooled standard deviation. And so there, whatever the endpoint might be, whether it's walking longer or having fewer depressive symptoms, it's converted into standard deviation units. So that's essentially the effect size uses the standard deviation as the metric. If we use for dichotomous or binary outcomes response or remission, we could calculate a number needed to treat or number needed to harm, which is another kind of unit. For effect size, you can do it within group, same principle, inflated a bit. But the basic point is it doesn't really matter because the drivers of both effect size and the NNT or NNH are the response metrics that you're measuring with respect to your clinical endpoints. And if you look at the discussion from neuroimaging about placebo, what's really clear is that the circuitry, the synaptic kind of activity, and the molecular signatures that are allowing this to happen at the intracellular level are all driven by whatever it is that you're using to treat the subjects and the pathobiology of the illness. So it will be different for pain than it would be for depression or for psychosis. So all of those behavioral symptomatic indicators relative to their essentially kind of biomarkers are specific to the response you're interested in, which is another way of saying there is no placebo response that's independent of what it is that you're asking in your clinical trial. I think we have to be very clear that in order to understand this and to use it in clinical research and to capitalize it on clinical practice, we just need to really understand it. And that's going to happen over the next 5 to 10 years. It's going to be an enormous amount of research trying to sort of figure out what this is, how to use it, and how to minimize the potential harms.
Well, I think that's an excellent point to end our program on today, and I think we're all going to be giving a lot more thought to understanding placebo effect in our clinical research experience. And I really would sincerely like to thank all of the panel members for their contribution to the program this morning, and thank everyone for your contribution and attendance as well.